got a number of cases. We'll go through them. We'll have some comment, we'll have some debate. Siddhartha, good luck.
Thank you, Aaron. So my name's Siddhartha George. I'm one of the cardiologists at University Hospital of Birmingham. So Ahmed and Aaron have both been involved in some of these cases. So these are a selection of cases from the last few years at our unit. I don't want to say that what we've done is definitely the right thing or definitely follows the guidelines all the time, but I think what we'll do is I'll present the case, you guys talk about what you would do, and then we can talk about what we did, and I'm sure some of the different, some of the colleagues from around the country and around the world may have a different view on things. So these are all real cases and these are their angiograms. And I think traditionally what Aaron does is I show the case, we show the angiogram, and he picks out someone to talk us through the angiogram. So this is a 62-year-old man from the outpatient clinic. He's got stable symptoms, he's got angina, he's got good LV and RV function on echo. He had a CTCA, which suggested there was significant disease, and he went on to have an invasive coronary angiogram. And
so this is case one. My advice to you that when you come into these things, case one is normally the easiest case. Does anybody want to volunteer? Thank you for volunteering. Can you comment on the angiogram for us, please?
There's this projection of the left coronary system. We've got disease in the second ventricular bit proximally, and also disease in the first OM. Assessment of the LAD at this point. Left main looks clear. Potentially some backfilling of the right system, suggesting maybe a CTO of the right. Could you have some more views?
yeah, I'll show you some
Good answer. Always ask for more views. If you want to, the trick now is to pass the microphone on to someone else. Pick someone who doesn't know about hands for, let the person sitting next to you. Just say what you see.
So it's a left-sided injection again. Again, the left main stem looks clear.
Okay.
Yeah, I'm not sure if I agree with all of that. I'll just go back to a couple of angiograms. Firstly, the first thing I would do when talking about the angiogram is to try and say, what kind of view this is. And this looks like a PA caudal view. And as the first kind of delegate said, it's not great for the LAD, but actually here you can see there is significant disease in the LAD. So in this view, which is a PA caudal, this is the left main stem, this is the circ, that's the LAD there. Actually, I don't think the left main is clear. I think there's at least a 50% distal left main stem lesion. As you said, the right looks like it's occluded. We can see it cross-filling. This circ is heavily diseased. I think, again, we tend not to comment on the mid-LAD until we see the cranial views, but it does look like it's diseased. This is a circ view, and actually you can see, this is the spider view, and you can see actually that ostial circ is critical, and you see more of the distal left main there. The distal left main is also severely diseased. And then we went on to the cranial view, and this is the LAD here, and that mid-LAD is severely diseased. So, in this situation we've got distal left main stem, severe LAD, severe circ. I haven't showed you the right yet, but it is cross-filling from left-sided injections. And then this is the right.
Who here wants to be a heart surgeon? Professor Labani?
Yeah.
I doubt you're going to make it. I doubt that. What would you like to do with this person?
It's a 62.
It doesn't work, it's a prop. It's a prop.
A 62-year-old male, diabetic, left main with triple vessel disease, so with good ventricular function, so coronary artery bypass grafts. I would lean more radial and vein.
Okay, where are you going to put the radial?
To the right.
Okay. Anyone else?
I need to see an echocardiogram before. I know it says good without being, but we have to look at the echocardiogram.
You do. You're correct. You're correct. But he looks trustworthy.
Yeah.
Come on. How can you not trust him?
At our MDTs, we do tend to look at the echocardiograms, but in the interest of time, I haven't included all of those pictures. But he did have good LV and RV function.
Yeah. Yes.
Is this a stent or calcification?
This is calcification, I think. From memory, this guy hadn't had a stent, so it's just visible calcium.
Now I use of the radial.
So I suppose you use the radial, but what would you do immediately after surgery then?
Immediately after.
Well, there's things to do before you operate on the patient.
So before you have to assess your right left radial.
What's the test called?
The Allen's test, and also assessment of saturation, and we also scan the radial to prevent opening it up to and see a calcified. So if there's a flow and any calcification without us on the handheld that we do for the vein, also we will assess, do all those.
And what would you do after surgery then?
After the surgery, when we do G10 infusion immediately, and then calcium channel blocker in terms of diltiazem.
What are you trying to prevent?
Spasm.
Yeah, the string sign after coming surgery. That's fair enough.
Yeah. Okay. Right. Yes, sir.
Good question. I know that you're supposed to use radials on high-grade stenosis, but when you've got a backfilling coronary, does that create issues with coronary flow? Because they're still getting flow from the left system. Does that?
It's a way, I mean, it's why we don't all die when we occlude a coronary artery. The fact that you've got collateral circulation means that myocardium still continues to be perfused, but it will create a competitive flow. It's also a way that our cardiology colleagues can find their way back into the vessel if they want to open up a CTO, but it's how collateral circulations work.
You are dealing with radiograph on RCA or SSL?
So the last radial I used was 15 years ago. So I do my memories. I just I do them.
Andy radial.
Yeah. I think for anything he would use a right mammary for, I tend to use a radial for. I have some concerns about competitive flow. I think there are fewer concerns with Rima's competitive flow. But here, I think he needs 5 grafts, being a radial, do it all.
Okay, everyone happy?
I wouldn't use the radial.
I know, but you're old. you're like me, you're old.
So why not?
No, I think it's straightforward. Memory and vein grafts.
Venous grafts.
Would be sufficient here. That will do a good job.
So everyone always comes and says, what should I say in the exam? Okay? That's what everybody says in this course. I'll tell you what to say in the exam. Yeah? Say whatever you do every day. Yeah? Do not change what you do because you're in an exam situation. So, if you're Professor Labani and your standard operation is the lemur and veins, he would have said he would use the lemur and veins. Yeah?
I will do that.
Come on, keep going.
We'll move on to the next one. So this is a 52-year-old man with chest pain and inferior ST elevation on his ECG. He's diabetic, he's got high blood pressure, he's a smoker, and he's got a family history. So lots of cardiovascular risk factors. He comes in as an inferior STEMI, and then the cardiologist doing the angiogram calls you down to the cath lab. So he's having an emergency coronary angiogram.
So this is a right coronary injection.
Yeah.
It shows artificial stenosis
Yeah.
in RCA.
Yeah.
I would like to evaluate whether the PD is actually coming off, because I can't see the septals very clearly on this one. And yes, he is right coronary dominant. So
Is he?
Huh?
Is he quite dominant?
I think I can see this. Well,
How do you know?
I would want to see the left coronary injection as well, because I'm so dominant.
Be careful what you say.
Yes. So this is left coronary injection.
Yeah.
He's got proximal LAD stenosis.
Yeah.
And not like big trunk between the proximal and the mid circumflex
Okay.
stenosis as well.
This is a cranial view.
But very small head. Not great.
You've been in Papua for too long.
Can still be grafted if it looks good.
Yeah, so
Great!
It's underfilled, that'll be fine.
Okay.
It's got triple vessel D.
Okay, you've been called out for the cath lab. What are you going to do?
Or he's having an inferior stent.
inferior STEMI, yeah.
In that case, can you PCI to the right and we can do a work stabilizing the. If he's getting chest pain, he's got ST elevation, I would PCI to the right, the
Yeah.
calculated artery, and leave him up for urgent graft.
Okay, so you don't want to graft him now? Does anyone want to take him to theatre?
There's only one thing planned for theatre, it's in the cath lab, it's got ST elevation.
You've got a balloon pump in.
It depends how long he's having this MI.
2 or 3 hours?
You can take him to theatre.
PCI to the right.
You can't, or you can?
You can.
Okay.
When it's open, it's right. As long as there is no mechanical complications of MI, as
Yeah.
long as he maintained the hemodynamic, no circulatory collapse.
And actually, these left-sided pictures I took after the right had been treated. So he has lots of disease in the left, and he was presented at the MDT after he'd gone home 3 or 4 days later. And the plan for him is to have an early outpatient bypass operation. So again, in emergencies, I guess you can do it on dual antiplatelets, but he hadn't had any angina prior to his inferior infarct. So he's treated his right. He's going to have dual antiplatelets for another month. Then he's going to have surgery on the LAD and the CERT.
Quite serious to know this. Why not to refer him as an inpatient for college?
Yeah, I guess it's risks and benefits, but he hasn't been having angina. I agree, it's a critical severe proximal disease, critical mid-LAD disease, but you would then have to probably operate on dual antiplatelets, as in if we interrupt those, it puts the stent on the right at risk. Another option which would not have been unreasonable would be if we had just done a balloon of that right coronary. The kind of situation we have, I mean, different people do different things, but if someone comes in with inferior ST elevation, I tend to take a guide to the right, and if the right is either severely narrowed or blocked, I would fix it. So I don't know what the left is going to show yet before doing the right. Some people would shoot the left-sided pictures first, and in that situation, maybe I would have said, oh, actually, he's got critical LAD disease, we'll just POVA the right, and he can have an inpatient operation. But having put the stent in, it's difficult then to pause the antiplatelets immediately.
Would be any difference if you put a stent or you do balloon? So.
Yeah, we'd be much more comfortable about pausing antiplatelets after just a balloon. Whereas actually,
No, I mean technically balloon or stent.
Well,
Balloon and graft or stent and discharge.
sorry, what's
So if you have a choice to balloon and send him for the grafts as inpatient, or to do stent and send him home and after that grafts. So what would be the difference for the patients now come?
Well, I think both of those are reasonable things to do. So if we had all that information before I stented the right, both of them would be valid things to do. So either POVAing the right and having inpatient surgery to all of them. But I think it's also reasonable to have stented the right and for him to have early outpatient surgery to the left system.
Would you not consider a bare metal stent rather than a drug-eluting stent?
No.
Would that be safer if we were going to proceed with another operation?
No, we tend to, I don't even think we've got bare metal stents on our shelves anymore. So when I started in cath labs in about 2010, even by then the European and American guidelines said bare metal stents only to be used in very short lesions with big vessels. So if someone had a 4.0 vessel, which was a short lesion, we would use it. But in the last 10 years, we don't even keep bare metal stents anymore.
If this lesion was opened by drug-eluting alone, not stent, you will bypass it?
It depends what results you got.
Yeah, again, it's very difficult.
If it was early, I would not.
Yeah, it's very difficult because actually with POVA and these drug-coated balloons, sometimes you can get a stent-like effect in that first bit. So there will no longer be a flow-limiting lesion possibly in that right coronary artery. And I don't know how a vein graft would do on something where there's obviously competitive flow, or a radial graft would do if there's competitive flow.
In the ones that I've been involved with, and very rarely do you get a beautiful picture. It's normally quite diseased still.
Yeah.
You know, having a lovely pristine looking endothelium's rare. I would graft them, and I wouldn't use an arterial graft.
I think there's disease in the vessel.
I would use vein. You know, all conduits have a use.
Vein will provide better flow, will avoid competitive
I think
flow, and it will close.
The bigger flow is a misnomer. The flow is directly related to the arterial bed you're supplying. So if you had a 50mm graft, it's not going to flow more into the right coronary territory. The right coronary territory, the coronary bed is the reason you get good or bad flow.
Will accommodate its capacity, not more.
But the point is that any graft will give you enough. You know, if you look at angiograms from 10 years after a arterial graft is going on, your mammary is about 5mm in diameter nearly every single time. They're adaptable. They're biological. They're not just dumb pipes. Veins are dumb pipes, unfortunately. They can't grow. They can become aneurysmal. But when you pressure test a vein without a valve on your syringe, you're subjecting it to 300 or 400, if not more, millimeters of mercury, and you damage the endothelial junctions, connections between each of the cells. I did some, my MD was looking at endothelial reactions, and any vein graft that had been dilated just wouldn't react at all. You kill them off, and that's why you don't get that first night spasm, because the vessel does not work, it's just a dumb tube.
Sadaka, next, please.
So the next patient's again acute coronary syndrome. So she's 62, she's diabetic, she's heavy, she's got high blood pressure, high cholesterol. She has an anterior T-wave inversion on her ECG, and this is her coronary angiogram.
Andre, make me proud.
So it's an injection into the left system.
Yeah. Tell me when you see it enough, and I can move on to the next.
Before it's fighting against the and you can see a big the LED bifurcation to the right, which looks relatively there is distal obstruction in the RTA.
Thank you. Right. Does anybody want to know anything more about this lady? Echo? Echo?
So she has pretty good LV function. So the EF, I think this was only about 3 or 4 weeks ago, 50 to 55%. So a little bit of anterior hypokinesia, but pretty good LV function. Very mildly impaired.
And we spoke about this as a big lady, so we would like to know the functional status of that lady, because she's diabetic, and we would offer her in this picture, we would offer her surgery with prognostic lesion in LED and DLV lesion. I would like to offer her surgery, so I would like to know more about the patient functional status as well.
Yeah, so all very reasonable. So actually at our MDT, the feeling was that pretty good surgical candidate in terms of, you know, targets and diabetic and multivessel disease, but some concerns about the raised BMI. So an anaesthetist went to see them. Their pre-morbid status was pretty good, not working, but you know, living independently, exercise tolerance of up to several kilometres. So the anaesthetist was fairly supportive and said that even if they had a slightly longer period in ICU or in recovery in hospital, they're very confident they could get them through. So they did go for surgery. What would you graft, do you think?
So the second question would be the convict. What? So So we have very significant stenosis before the diagonal and the LED. So I will be grafting the LED and the diagonal and the VLV. And in my unit, we will do Lima and 2 veins.
And what would you put the lemur onto? Because here the diagonal's huge, isn't it? Yeah.
And it's reaching down the
So I mean, this is the true LED because you can see the septals coming off it. But actually, after here, the diagonal looks like it's supplying possibly a bigger area.
I'm going to step go Lima to LED and I'll put vein to the diagonal and vein to the VLV.
That's mine too. So you got it right. Anyone else? Anyone else want to do anything different? Does everyone want to put the lemur to the diagonal?
Sequential graft.
Sequential graft?
Yeah, I put it on both. It probably would reach both. It's pretty proximal. Take off the diagonal, and the PL has got a second PL branch as well. So there's going to be a decent amount of lateral wall supplied by the PL, the 2 PLs, and so a radial to that. We've got a decent run.
Noah?
Yeah, I'll do both. I think that tight narrowing, there's the LED that still gives off a septal, and that big diagonal goes to the apex. So a sequential here, and just a short bit of the right to go down to the PDA. I'd spare this woman an incision in her thigh.
Yeah,
I think
she's
someone's got
badly, isn't she?
a BMI of 45. She'd struggle with lead wound healing.
You worried about the sternum?
I'd use double wires and make sure that the sternum is rock solid when I'm done with her.
How do we know what's Sadako?
Well, it's
so confusing. Lots of wiggly things.
Unfortunately, a lot of people, they don't conform to what the textbooks would say. So usually you would get the PD should be going off here and providing the septal. So I think this is the PD here. This is a very big PLV branch, which has then got disease in it, which bifurcates later. So, easiest to differentiate is when the right comes down here, you get a nice PD, and then a single branch going off here. Sometimes you see this vessel, you can, as you said earlier, you can have a codominant system where this is quite small, and is it an RV wall branch or is it a PDA? And generally I allow the most senior person in the room to say what they think it is. It's true. Like,
which one is it?
I'll give an opinion. I think the PD comes off, and that's actually the continuation of the right in the AV groove before the second PD comes off, and then there's a smaller third.
Yeah.
But in the OR, it's you appreciate how that segment after the first PD is really in the AV groove, and that means to me it's the right coronary and right dominance.
I think everyone would agree this is a right dominant system. Yeah.
Okay, happy? Next. Have we finished yet? Are there more?
There are more. We can stop whenever you
keep
want
going.
to.
Do everyone want to keep going?
Yeah. So this is
We're all enjoying it now.
61-year-old man, comes in with an acute coronary syndrome, no localizing changes on his ECG, but he's had a trop rise. He's got some cardiovascular risk factors. He's got high blood pressure. He's an ex-smoker. Again, I haven't shown you the echo, but he's got good LV and RV function. And this is his angiogram.
It's a good job I've got long arms, because people hiding away there in the middle. Remember, you can always ask for more views once you run out of things to say. So sorry, you did something else. Distal left main stem disease. Yeah. Sudhakar?
Yeah, I'd agree. I mean, I think what you said earlier is reasonable. I have to say, I think even on this first shot, it looks like there's at least there's at least a 50% lesion, isn't there? Because it's really wide here, and even before the bifurcation, it really tapers down. But I think especially on the spider view, here, it looks pretty tight, doesn't it? It's 70-80% distal left main stem lesion. So if you weren't sure, so say you're presented with something and you're not convinced the left main or the distal left main or whatever is significant, and the cardiologist is telling you that it is, what other things can you do? What are the options?
IVUS.
Yeah, so IVUS is an excellent option. So the things you could do are you could do a pressure wire, either in the LED or the circ, or probably what I would do is IVUS, and here you can get an exact area. And generally for a distal left main stem, 6 millimeters squared would be considered significant. Again, these are all just validated against other tests like stress MRI and a pressure wire. So IVUS is an excellent suggestion for if you're not certain. But here I was confident this was significant, so I didn't do any further imaging, but I did take it to the MDT. So what would you do?
What on the right?
The right, I think is okay.
Pass the stick forward.
Yeah, so on injection of the right coronary artery, we can see that there is no flow-limiting disease. It is again right dominant system, so we don't need to do anything about it. Whereas for the left, which is left main, I would go for Lima 2 RAD and then main drop.
Professor Lavani? You agree? Sadaka?
Anyone pushing for PCI, or would everyone?
What's syntax score?
Well, you tell me. You heard a little bit earlier about, is the syntax score here low, medium, or high?
Low.
Yeah, it's going to be low, isn't it? Yeah, it's low. Because syntax, again, the calculation when you do it properly is quite complicated, and you can obviously use the website. But generally, it's complexity of disease, the number of lesions, is it calcified, is there thrombus, how long the disease is. And this would actually just count as low, because there's just one lesion. It's probably a trifurcation, so that adds to the complexity a little bit, but it's not particularly calcified. So this would be a low syntax score and a single distal left main stem lesion. Do you think at all your units the cardiologist would always bring this kind of case to the MDT?
I think because that should be treated with surgery, in my opinion.
I think this is the sort of case that the guidelines having the heart team added to them was designed to try and combat, to make these discussions where there is perhaps equipoise. If your colleagues have already done them without asking, you don't get that opportunity.
Yeah, I wouldn't be surprised if there are quite a lot of these kinds of cases being done without coming to the MDT. I have to, my approach to this, I guess a lot of it depends on their age and comorbidities. So, if it was an 85-year-old lady who comes in with an NSTEMI, if she's got a distal left main stem and she's lucky enough not to have other disease elsewhere, would I necessarily take it to the MDT? I don't think I would, and I think quite often in those situations I would have just treated it. I think the things here are the patient's quite young, no particular comorbidities that would preclude surgery, and also just, again, the syntax score here is low, but it is a trifurcation, and it's very hard angioplasty-wise to manage all 3 limbs. You can look after 2 of them okay, and it's slightly uncertain what would happen to the 3rd, and it'd be a bit awkward if I did get into left main PCI and then I have to call for help from the surgeon, and then the first thing they might say is, did you take it to the MDT? And then I say, oh well, So this patient, I can't actually remember what happened to them. So Aaron and I had a disagreement. I can't remember if this was a patient who during COVID ended up with angioplasty because, at the time we did have pressures on ICU beds and all the rest of it, or whether because of the trifurcation they ended up with surgery. And I can't quite remember what happened to them. This is from 2 or 3 years ago.
I think this is the COVID patient. Because I think it's the COVID patient, and I think PCI because of COVID. But alternatively, I think you could offer this man either treatment. If you PCI'd him, you're not going to ruin anything for us in the future.
Yeah.
And I think this would be reasonable to discuss with the patient.
Yeah.
Longevity versus a less physiologically insulting treatment.
Yeah, and again, I think it's interesting because it's some of these younger patients, it's really about lifetime management. Many of them will get both angioplasty and surgery, and in a way, some of the times what you're arguing about is what they're going to have first. If you're 50-something and you've got left main and you have a perfect operation, a perfect bypass operation, in your 60s and 70s, you will still come back with something else, and probably you're not a candidate for redo, and you would need stents. Equally, if I did angioplasty this guy during COVID or whatever, very likely that within the next 10 years or 15 years, he'll come back in with something and end up needing probably a bypass. So I think sometimes a lot of these younger patients will end up with both in their lifetime.
I think what's important
you should involve the patient in the discussion.
I think what's important here is the fact that this patient was discussed.
Yeah.
Because, you know, that's far more important than did he have treatment A or treatment B.
Yeah. Yeah.
Roshni?
So what if this situation, assuming the patient is actually not maybe or positive, but what if this patient presented with exactly the same thing? So this one vessel that has the stenosis in it, but had ST elevation with ongoing chest pain, then what would you do? Would you?
Yeah, I have to say you don't very often get. So usually for ST elevation, you need to have occlusion and lack of flow in that vessel. So that first one, you know, that inferior STEMI I showed you, it's quite unusual because there's actually still normal flow after that tight occlusion, and usually that's just intermittently occluding and closing. Usually a left main stem, the times you rarely see a left main occlusion presenting acutely because they have sudden death. I've had a few out of hospital arrests where you've got a critical distal left main stem. Usually on their ECG they would get ST elevation AVR, maybe widespread depression elsewhere. If I thought I could treat it, if they have STEMI or no flow in the left main, I would just angioplasty it. Just because I don't think patients who come in that situation would do very well waiting for theatre and trying to go on to have emergency surgery whilst having ST elevation.
Would you consider putting a balloon pump to see if that helps with the ST elevation and then referring for emergency surgery, or would you try to just?
I don't think I would. Just those people where they've got say ST elevation critical left main, every minute, every few seconds is important. And balloon pump, I guess it would take another 10-15 minutes to get the femoral access, put it in, and that might be too long for those patients.
Is there a difference length for the left main which gives you a cutoff of whether you would deploy a stent or not?
What do you mean?
As in like
a length, if it's like a short left main.
Yeah.
No, like it's like a short left main.
Yeah.
And there is a left main disease with a low syntax score. Would you still, and if there's no trifurcating lesion,
yeah, I don't think the length of the left main matters at all, but where it is in the left main does matter. So this is distal left main stem, so you will have to do a bifurcation procedure for the LAD insert to protect the limbs. If you have either ostial left main stem or just body of left main stem, it is actually much easier to PCI it because there's no, you're not going to lose a vessel when you put the stent in. And actually, this kind of distal left main is much more likely to make an interventionist take it to the MDT and say they should have surgery. Whereas if it was just a short mid-vessel lesion, you would say, I can probably get a very good result without any risk or without any excess risk.
One last question.
If this was in the original circumstances, this was left dominant circulation, would that make you tip towards surgery more?
It might do. I mean, it will make the PCI procedure slightly higher risk because obviously when the stent goes up, you're occluding all flow, and in that situation you will have no coronary flow at all.
Okay, that's lunch, everyone. So, thank you, Andy. Thank you, Noah. Thank you, Mahmood. Siddhartha, thank you.